Welcome back to the deep dive. Our mission today is, well, it's ambitious. We're taking a stack of dense, critical sources in gynecologic oncology, and we're aiming to turn them into really mastery-level knowledge for you.
Absolutely.
We're undertaking a rigorous professional deep dive. Our focus today, specifically the high-stakes, very nuanced world of vulval and vaginal cancers.
That's exactly right. And this material, it really demands a level of detail that goes far beyond just a simple review. We're genuinely aiming for elite comprehension here.
Yeah.
Our focus is squarely on the evolving standards of care. So analyzing the epidemiological realities, mastering those crucial differences in pathological classification.
Which are key.
They really are. And detailing the modern surgical paradigms that have, dramatically shifted management away from, frankly, mutilation towards preservation.
And we're dissecting diseases traditionally associated with, well, high mortality and high morbidity in the genital tract. But importantly, we're also zeroing in on what our source material actually calls the success story of modern gynecology.
Yes, the detection part.
Exactly. The ability to detect and, crucially, conservatively manage those pre-invasive and micro-invasive stages. To truly master this, you need to understand the critical nuances of VIN, that's vulval intraepithelial neoplasia, and how its management really sets the precedent for individualized treatment of invasive vulval cancer later on.
Precisely. But before we dive into those, microscopic details, we really have to establish the context. Where do these specific cancers, which are often perceived as rare, especially in Western settings, fit into the overwhelming global burden of disease? Take IO, the global and regional burden of genital tract cancers.
Right. Contextualizing the importance here is fundamental, and the sources, they immediately force us to look at that global health dichotomy. It's quite stark.
It really is.
In developed countries, we often focus on breast cancer as the predominant female malignancy, right?
That gets a lot of the attention.
But genital tract cancers, they remain major killers, particularly in the developing world. And the tragic part is they're potentially preventable through things like screening and vaccination.
And that epidemiological contrast, that's really the first major point for mastery here. When we look at the incidence data, specifically, table 37.1 in our sources, the disparity for cervical cancer is enormous, just staggering. About 80% of cervical cancer incidence occurs in developing countries versus only, 60% in developed countries?
That 20-point difference, that's huge. It signifies a colossal failure in public health access, doesn't it? Affecting millions globally.
It really does. But then you see the pattern completely flip when you look at cancer of the the uterine body.
Right. The incidence there is 25% to 30% in developed countries. But it just plummets to only 5% in developing countries. That inversion, it's very telling, isn't it?
It speaks volumes, absolutely volumes about the underlying causes, the aetiological drivers. Uterine cancer, often driven by unopposed estrogen, it's highly correlated with lifestyle factors more prevalent in wealthier nations, things like obesity, metabolic syndrome.
Right.
Meanwhile, cervical cancer is predominantly driven by infectious factors, mainly HPV, which, well, it thrives where screening and vaccination coverage is low. Simple as that, unfortunately.
And the cancers we're specifically focusing on today, vulva and vagina, they maintain a much lower and actually more consistent incidence globally. Vulva incidence ranges from, 4% to 5% in developed nations, and 1% to 5% in developing nations. Pretty close. And vaginal cancer, as we'll get into later, that's the true rarity, less than 0.2% globally.
Just tiny.
So to really appreciate the regional burden, the sources give us this powerful comparison across Southeast Asia using age-standardized rates, or ASRs.
Right, the ASR. That lets us compare apples to apples, doesn't it, in terms of population risk? Exactly. And the data, well, it confirms the overwhelming presence of cervical cancer across the Indian subcontinent. India reports a massive ASR of 30.7. Bangladesh is close behind at 27.6. Sri Lanka at 28.8.
Those are huge numbers. These are the high-volume diseases consuming resources and, sadly, driving mortality in those health systems.
Yet the sources point out one really critical exception that, an elite learner absolutely must memorize: Pakistan.
Yes. The data there deviates sharply from its neighbors.
It really does. In Pakistan, breast cancer actually takes the lead with an ASR of 50.1, just massive. And that contrasts dramatically with cancer of the cervix, which records a relatively low ASR of just 6.5.
That is highly noteworthy. I mean, why would the source suggest Pakistan aligns more with high-income Western nations in this specific cancer pattern? It's so different from its neighbors.
Well, the sources don't give us one single definitive answer, but the deviation suggests, complex interactions, lifestyle factors, genetic factors, possibly cultural practices influencing reproductive habits, and exposure risks. It shows us that epidemiology isn't uniform, not even within, tightly bound geographical regions. It's a crucial counterpoint to that broader regional trend. Reminder not to overgeneralize.
But regardless of which cancer is leading in any specific country, the ultimate public health takeaway, which the sources really reinforce, is vital. Both of these major killers, cervix and breast cancer, they are fundamentally amenable to early diagnosis and cure.
Absolutely critical point.
And that fact, well, it drives the entire effort behind screening programs worldwide, doesn't it?
Okay, so moving now to the specific pathology of the vulva, we've established its rarity only accounting for about 1% to 5% of all genital tract cancers. And generally, we see a slightly lower incidence in developing nations.
Why is that thought to be?
Well, possibly due to a lower prevalence of some of the associated risk factors, like HPV infection and smoking, compared to wealthier nations. Although, that's constantly shifting with globalization and lifestyle changes.
Okay, let's detail the grouping of malignant tumors. For mastery, you really need to divide this clearly. Two main categories: preinvasive lesions and invasive lesions. The preinvasive group defines that cellular abnormality that hasn't yet broken the barrier, the basement membrane. And this includes intraepithelial cancer, which we call VIN,
Right.
Bowen disease, Paget disease, and also microinvasive melanoma in situ.
But the vast majority of our focus today, and clinically, revolves around the invasive lesions. And these are just dominated by squamous cell carcinoma, or SCC.
Right, SCC. That single type comprises a staggering 90% of all invasive vulval cancers.
90%. So you might ask, if 90% is SCC, why do we need to focus so much on the remaining 10%?
Good question. Why?
Because that remaining 10%, well, they can be highly aggressive and carry unique risks. We're talking about melanoma, which accounts for maybe 1% to 5%, sarcoma, around 2%, and then the truly rare ones, adenocarcinoma and basal cell carcinoma, sometimes called rodent ulcer clinically, each accounting for about 1%.
Wow, really rare.
Extremely rare. But their rarity means that when they do appear, they often present significant management challenges. They have different biological behaviors, different nodal spread patterns, things you absolutely must be prepared for. You can't just assume it's SCC.
It's also essential to know the anatomy of the disease, where it typically occurs. Most malignant lesions are located on the labia majora.
Correct.
But what's fascinating and clinically relevant is this factor of multifocality and how it relates to the patient's age.
Yes, this is a key clinical distinction you need to pick up on. Multifocal lesions, cancer appearing in multiple separate spots, occur in about 5% of cases. And they're typically associated with younger women, generally below 40 years of age.
And often linked heavily to HPV infection, right?
Exactly. That's the usual suspect there. Conversely, the single unifocal lesion, that's the classic presentation for older women, and it's often linked to chronic inflammatory conditions like lichen sclerosis. So that clinical difference, right away, it informs your suspicion about the underlying cause.
We also have to consider the potential for overlapping cancers. I mean, the vulva isn't an island, is it?
Not at all. It can be the site of metastatic disease from distant primaries, sure, but more commonly it can coexist with cervical cancer, particularly if the entire pathogenesis, the whole disease process, is driven by the human papillomavirus.
Ah, the field effect.
Precisely, reinforcing that concept of a field effect across the entire lower genital tract. One hit here might mean trouble elsewhere, too. #3. Deep dive into preinvasive vulval neoplasia. VIN. Okay, now for the real deep dive into vulval intraepithelial neoplasia, or VIN. The definition here is precise, and understanding it dictates the whole treatment philosophy.
Okay.
So VIN is a cellular abnormality that is limited strictly to the vulval epithelium. The key word is limited. The cancer cells are restricted by the intact basement membrane, and critically, they have not yet spread into the dermis.
And the definition also excludes the keratinized layer of the skin.
Correct. No spread into the dermis, and it excludes that top keratinized layer.
So when you're looking under the microscope, what's the pathologist's fingerprint for VIN? What confirms it?
Histologically, we look for three classic features. First, acanthosis, that's a thickening of the prickle cell layer of the epidermis. Second, intraepithelial pearl formation, usually down at the reap pegs. Those are the extensions of the epidermis into the dermis. And third, often you see a chronic inflammatory reaction in the underlying dermis. Those three together are pretty characteristic.
Now, the naming, the nomenclature for VIN, it changed dramatically. And every learner, everyone trying to master this, must understand the reason behind that 2004 ISSVD classification change. ISSVD being the International Society for the Study of Vulvovaginal Disease.
Yes, this was a really critical standardization. The sources state that the old VIN-I designation, it was effectively dropped.
Why was that?
Well, it suffered from poor clinical reproducibility. It was often difficult to reliably differentiate from just benign changes or maybe mild atypia, and clinically, it often regressed without any intervention anyway.
So less clinically significant.
Exactly. By standardizing, they ensured that what we call VIN today, which used to be VIN2 and VIN3, truly represents a high-grade lesion, something with real malignant potential that needs attention.
Okay, so we use a simpler VIN designation now. But the critical distinction has shifted, hasn't it? It's now classification into two types based on the cause, moving away from just grading severity towards understanding the etiology.
Precisely. A much more useful distinction clinically. We now have the usual type VIN. This is strongly related to HPV infection, tends to occur in those younger multifocal cases we mentioned.
Okay.
And then we have the differentiated VIN. This type is unrelated to HPV infection. It's generally associated with chronic inflammatory conditions like lichen sclerosis, and it often presents as that unifocal lesion in older women. This etiological split, it guides not just treatment, but also the surveillance strategy afterwards. Very different pathways.
Let's talk etiology, the causes. The sources are really clear here. HPV infection is paramount, implicated in what, a staggering 70% to 80% of cases overall? It's huge. And specifically, type 16, that's the overwhelmingly common culprit, present in 60% to 90% of those HPV-positive VIN cases. But, the list of cofactors and risk factors, it's long, and they often work together synergistically.
Like what else?
Well, we also have to list herpes simplex virus 2S, smoking, which is a powerful independent carcinogen. We can't forget that, chronic irritation. Any immunosuppressive states like HIV, or even just pregnancy, which causes transient immunosuppression. And then general conditions. Poor nutrition, maybe poor hygiene. Even local moisture retention can play a role. It's multifactorial beyond HPV.
And this strong HPV link, it leads to that critical clinical connection we touched on. 50% of VIN cases have sequential or concomitant neoplasia somewhere else in the lower genital tract, especially cancer of the cervix.
Right. It strongly suggests common etiological factors that field effect again. If HPV is involved, it can affect multiple sites.
However, there's a vital point for mastery here, a kind of contradiction noted in the sources. Invasive cancer doesn't always follow a pre-invasive lesion, does it? No, absolutely not. It's a common misconception to think VIN is some mandatory precursor. Invasive vulval cancer can, and often does, develop de novo completely new without a preceding VIN lesion. This is particularly true for that differentiated type VIN associated with lichen sclerosis. It can just appear.
We also need to separate out the risk of progression based on age, because this really dictates our confidence in just observing versus intervening surgically.
This is absolutely the core of conservative management. In younger women, let's say typically under 40, where VIN is almost always related to HPV infection, the prognosis is, well, remarkably favorable.
How favorable?
There's about a 90% chance of spontaneous regression. It just goes away on its own. And only maybe a 10% chance of progression to invasion. This high rate of resolution is exactly why observation is often a valid strategy in this group.
But the picture shifts completely for elderly women.
Completely. In the elderly, VIN is strongly associated with those underlying conditions like lichen sclerosis, chronic irritation. And these cases carry a significantly higher and often more immediate chance of progression to invasive cancer. So intervention is usually mandated much earlier and more decisively in this older population. You can't really wait and see as readily.
Okay, moving to the clinical presentation of VIN, the early symptom very often is pruritus, just intense itching. And this often becomes the diagnosis delaying factor, doesn't it? Because it's so commonly misdiagnosed and treated empirically, maybe with antifungal creams, as a simple fungal infection.
Indeed. It can sometimes be years of just treating the symptom, trying various creams, before the correct diagnosis is finally made. Later on, patients might develop soreness, dysuria pain with urination, and dysperian pain with intercourse.
And the lesions themselves, how do they look?
They can look quite variable, sometimes flat, sometimes warty, sometimes papular. They might develop pigmentation, becoming darker. Most commonly, they affect the labia majora. But critically, because the disease is still restricted to the epithelium at this stage.
Right, preinvasive.
The inguinal glands, the lymph nodes in the groin, they're typically non-palpable. Feeling nodes usually means it's gone beyond VIN.
Now, given that cytology, like a simple scrape test, a pap smear equivalent for the vulva is notoriously poor because of the heavy keratinization of the vulval skin.
Yeah, it doesn't work well there.
Biopsy is absolutely essential, isn't it? It's really the only way to confirm the diagnosis and, crucially, to differentiate VIN from non-malignant dystrophies, which can also cause itching.
Absolutely. Biopsy is king here, and we rely on specific visualization aids to make sure that biopsy is taken from the most representative, the most abnormal area. You can't just poke anywhere.
What kind of aids?
Well, sometimes simple things work. Applying KY jelly, believe it or not, can sometimes improve visualization of the underlying microvasculature. More standard is using 5% acetic acid.
Like in colposcopy.
Exactly. It causes characteristic white areas, acetowhitening on the abnormal epithelium. But the classic and often superior technique involves staining with 1% toluidine blue.
Okay, explain the toluidine blue technique for the listener. How does that work?
Right, so toluidine blue is basically a nuclear stain. Normal, healthy, keratinized skin resists the stain, doesn't really take it up. But areas where the epithelium is highly active, maybe rapidly dividing like in VIN, or where the skin has been broken, denuded, or ulcerated, these areas will take up the stain.
And they turn what color?
They turn a distinct royal blue. This effectively marks the abnormal areas, the hot spots, accurately guiding the surgeon or clinician to the highest risk region for those selective biopsies. Is a very smart, targeted approach.
And since we established earlier that maybe 50% of VIN cases have concomitant disease elsewhere, concomitant screening is mandatory, right? Not optional.
Absolutely mandatory. Colposcopy and a pap smear of the cervix are required. You have to rule out simultaneous preinvasive or invasive cancer there. And if the vulval lesions extend back towards the anus into the perianal region, then proctoscopy and anoscopy are necessary too to check for extension into the anal canal.
It's a holistic approach.
It has to be. You don't want to treat the VIN and miss a cervical cancer, for example. That would be disastrous.
And this leads us to, well, a more modern diagnostic frontier, which really helps guide that conservative management approach. DNA studies, looking at aneuploidy versus euploidy.
Yes, this is crucial, particularly for deciding on observation versus intervention in younger women. Aneuploidy, meaning an abnormal number of chromosomes in the cells, strongly suggests genetic instability.
Which implies?
Which implies a higher possibility of progression to invasion. So, if aneuploidy is detected, treatment is generally mandated pretty immediately. You don't want to wait.
But if you find euploidy?
If we find euploidy, a normal chromosome count, especially in a young woman, this indicates a lower risk. It allows us to more confidently utilize that observation window, maybe for up to 6 months, banking on that high 90% chance of spontaneous regression.
So DNA ploidy helps stratify risk.
Exactly. It's the difference between performing a procedure right away, maybe unnecessarily, and simply watching the lesion potentially resolve on its own. Huge implications for the patient.
This diagnostic rigor really informs the management philosophy, which is based on 3 critical goals. First, obviously, relieve symptoms like the itching or soreness.
Of course, that's paramount for quality of life. The second goal is preventing progression to invasive cancer.
Yeah.
We know 5% to 10% of high-grade VIN lesions, the old VIN III, will progress within about 8 years if left untreated. So long-term surveillance is absolutely non-negotiable even after treatment.
And the third goal, this really underscores that theme of minimizing mutilation.
Yes, the third goal is avoiding radical mutilating surgery. The traditional radical vulvectomy causes severe genital disfigurement, chronic pain, significant sexual dysfunction, or dyspareunia. That's especially unacceptable for the younger women who are increasingly being diagnosed with this condition today. We have to do better.
Okay, let's detail the specific treatment pathways now, maybe for a complex case, as outlined in the sources, like in Table 37.3.
Right. So observation, as we said, remains a legitimate strategy, but only for those specific low-risk cases. Young women, usually with multiple focal lesions who are HPV positive, and crucially, show euploidy on DNA study.
And you observe for how long?
Up to about 6 months, especially if the VIN may be developed during a transient immunosuppressive state, like pregnancy, where it might resolve as her immune system recovers.
But if the lesion is unifocal, or it's persistent, or it's in a higher risk patient, then excision is the standard, right?
Yes. Wide local excision is the standard there. And wide means at least a 2-centimeter margin of normal skin around the lesion, ensuring you get clear pathological edges. Simple vulvectomy, removing the entire vulva that's really reserved now only for very elderly, perhaps frail patients with very extensive disease who maybe can't tolerate more sophisticated reconstructive surgery, or for specific diseases like widespread Bowen's disease. It's not a first-line treatment anymore.
Okay, so for widespread, multifocal, or persistent lesions where you need aggressive removal but you want to avoid that severe disfigurement, the more conservative surgical options come into play.
Exactly. This is where we see the real ingenuity of surgical modification develop over the years. One key technique is the skinning vulvectomy, described by Rutledge and Sinclair.
How does that work?
It involves removing just the skin and the epithelium containing the VIN, but preserving the underlying subcutaneous tissue, the fat and connective tissue. Then, crucially, you cover the defect with a split-skin graft.
And the graft is essential. Why?
The graft is essential because it avoids the tension and scarring that you get if you just try to pull the edges together. That tension and scarring is what leads to the disfigurement and the subsequent dyspareunia. The graft maintains pliability.
Clever. What about ablative therapies?
We also utilize ablative therapies like CO2 laser vaporization or laser excision, which were really popularized by Townsend. Laser therapy is often favored because it tends to minimize pain and scarring compared to traditional scalpel excision.
Any downsides to laser?
Well, it may not be suitable for lesions very close to the urethra or the anus, where precise depth control is absolutely critical and may be harder to achieve with vaporization. You need tissue for pathology, too, sometimes.
Are medical options still relevant, maybe outside of treating recurrence?
They're generally adjuvant or maybe second-line options now. Local application of agents like dinitrochlorobenzene or 5% testosterone cream or 5-fluorouracil 5-FU has been used, though 5-FU is now mainly used for managing local recurrence, partly because it can be quite irritative. And of course, the underlying success story, really the ultimate prevention, is the prophylactic HPV vaccine, which addresses the root cause for 70–80% of these VIN cases in the first place, especially in younger cohorts.
But regardless of the treatment chosen, observation, excision, laser, whatever the requirement for lifelong follow-up remains absolute.
It cannot be overstated. Recurrence is a major risk. It occurs in 20% to 30% of cases, even after apparently successful treatment. And remember that potential progression time is lengthy. It can take up to 8 years for VIN to become invasive cancer. This just dictates a long-term, high-vigilance surveillance strategy that extends far, far past the initial cure. You can't just treat and forget.
All right, transitioning now from pre-invasive to established invasive cancer. We have to start with the most critical category for modern practice, microinvasive cancer. This corresponds to FIGO stage IA. And this definition, it's what allows us to avoid the lifelong morbidity associated with that really radical treatment.
Yes, the definition here, you need to internalize it with absolute precision. Microinvasive cancer, sometimes called SIVC, that stands for superficially invasive vulval cancer, is defined by 2 very specific numerical parameters.
Okay, what are they?
First, it must be a single squamous cell lesion, 2 centimeters or less in maximum diameter. Second, the depth of stromal invasion must be 1 millimeter or less.
Okay, let's pause on that 1 millimeter depth. Why is that threshold so incredibly clinically significant?
1 millimeter is the critical boundary. Decades of studies show that if the invasion depth is confined to this very superficial level, the risk of lymphatic spread, the risk of the cancer cells getting into the lymph nodes, is negligible. We're talking less than 1%.
Less than 1%. Wow.
Which means clinically, it allows us to confidently avoid the inguinal lymphadenectomy, the removal of the groin lymph nodes, and that procedure carries the high risk of chronic leg lymphedema, infection, and subsequent poor quality of life. So achieving a stage IA diagnosis, that basically means achieving surgical salvation for the patient, preserving their quality of life.
Huge difference. However, we must explicitly note the exclusion criteria here. This definition doesn't apply to everything.
Very important point, yes. This microinvasive classification, stage IA, it's only for squamous cell carcinoma. Adenocarcinoma and melanoma are specifically not included, even if they meet the size and depth criteria.
And why is that?
Because these 2 cell types, adenocarcinoma and melanoma, they just have a much, much higher propensity for early lymphatic spread. They're more aggressive in that sense, meaning that even a tiny 1 millimeter deep melanoma might already have traveled to the lymph nodes. So you would likely need nodal dissection regardless of the primary tumor size for those types. You can apply the SEC rules to them.
Okay, so once the disease progresses beyond stage IA, understanding the predictable pathways of spread becomes paramount for planning treatment. The sources detail the systematic lymphatic spread that was first described by Perry Jones.
Yes, the Perry-Jones system outlines the logical, stepwise progression. The disease spreads first to the superficial inguinal nodes. Those are the ones you can often feel in the groin crease. If these nodes become totally blocked by tumor,
Mm.
that's what causes the classic leg edema, the swelling. From there, it spreads deeper to the deep inguinal nodes, and then it reaches the absolute key anatomical landmark in this field, the gland of Cloquet.
Cloquet's gland, what is that exactly?
It's the lowermost external iliac lymph node sitting right at the top of the femoral canal. It's like the gateway to the pelvis. Only once the cancer breaches Cloquet's gland does it proceed upwards into the true pelvic nodes, the external iliac, obturator, and common iliac nodes. Reaching Cloquet's means pelvic involvement is likely.
Now, the vulval anatomy itself introduces a unique complication, doesn't it? The potential for midline crossing.
Indeed. While tumors located far laterally, way out on the labia majora, rarely spread to the contralateral, the opposite side. Any centrally located lesions, those involving the clitoris, the fourchette near the vaginal opening, or the midline perineum, well, these involve the contralateral nodes in about 25% of cases.
Right.
Because of crossing lymphatics. There are lymphatic channels that cross the midline in that central area. Furthermore, the lymphatics draining the clitoris itself are distinct. They can actually drain directly into the deep pelvic nodes, bypassing the standard inguinal chain altogether.
Which makes clitoral involvement particularly high risk.
Exactly. It means the disease could already be in the pelvis even if the inguinal nodes feel negative. A very important point for staging and treatment.
This brings us right back to prognosis, where nodal involvement is confirmed again and again in the sources as the single most crucial predictor of outcome. And the rate of involvement just rises dramatically with stage.
Look at the data. It's stark. Stage I has only about a 10% chance of nodal involvement. Stage 2 jumps up to 30%. Stage 3 skyrockets to 70%. And by stage 4, it's virtually 100% nodal involvement. This progression dictates everything about treatment planning and prognosis.
Okay, let's review the critical thresholds of the FIGO staging system. The 2009 version mentioned in the sources focusing specifically on how relatively minor changes in tumor size or node status can force quite dramatic shifts in the stage.
Right. So stage I is defined as disease confined strictly to the vulva or the perineum with negative nodes.
Yeah.
We already defined stage IA, that's less than or equal to 2 centimeters in size, less than or equal to 1.0 millimeter invasion depth, and negative nodes.
Okay.
Stage IB means either the tumor is larger than 2 centimeters or the invasion depth exceeds that critical 1.0 millimeter threshold, but still critically with negative nodes.
And this is the point where lymphadenectomy has to be considered.
Yes. Even if the primary lesion is still relatively small, crossing that 1.0 millimeter depth boundary means the nodal risk has crossed the safety threshold. Lymphadenectomy, or at least sentinel node biopsy, becomes necessary.
Okay, then stage 2 involves extension to adjacent perineal structures, like the lower one-third of the urethra or vagina or the anus, but still, crucially, with negative nodes. The moment nodal involvement is confirmed pathologically, we immediately jump to stage 3.
Correct. Stage 3 is entirely defined by having positive inguinofemoral lymph nodes. The source material breaks this down into 3 substages: I-A, IIB, and IA. Understanding these numerical definitions is vital because they reflect the volume of disease in the nodes, which directly dictates the need for adjuvant radiotherapy after surgery.
Okay, break down ICA for us.
Stage ICA signifies relatively low volume nodal disease. It's defined as either 1 lymph node metastasis that is 5 millimeters or greater in size, or 1 to 2 lymph node metastases, both of which are less than 5 millimeters.
So size and number matter here. What about IB?
Stage IV represents higher volume nodal disease. That's defined as 2 or more positive nodes that are 5 millimeters or greater, or 3 or more positive nodes that are less than 5 millimeters. So more nodes or larger nodes.
And stage IC, that seems different.
Stage ITI is the pathological finding that overrides both size and number. It's defined by positive nodes with confirmed extracapsular spread, meaning the cancer has broken out of the capsule, the boundary of the lymph node, and started invading the surrounding fatty tissue. This signifies a much higher risk of local recurrence and mandates aggressive adjuvant therapy, usually radiation, regardless of the node size or number. It's a bad prognostic sign.
Right. And finally, stage 5 involves invasion of other regional structures like the upper 2/3 of the urethra or vagina, the bladder or rectal mucosa, or, of course, distant metastasis elsewhere in the body.
And we confirm again, groin node status is the single best prognostic predictor. Uninvolved nodes grant roughly a 90% 5-year survival rate. Positive nodes cut that rate drastically depending on the extent defined by ITI, AA, B, or C. It's everything. #tag this. Advanced diagnosis and individualized invasive management.
Okay. In terms of advanced diagnosis for evaluating that crucial nodal status, imaging is obviously used. But the sources make a strong, maybe slightly counterintuitive argument that some historical techniques were actually superior for detection sensitivity in some ways.
Yes, this is a classic point that's often missed in the era of high-tech scans. CT and MRI scans are, of course, standard for looking at large area staging, checking for distant spread, looking at pelvic nodes. But the source material notes that traditional lymphography,
Which isn't done much anymore.
exactly, it's largely fallen out of favor.
Yeah.
But it was actually superior for detecting smaller metastases in the inguinal nodes specifically, nodes between 2 and 5 millimeters in size. CT scans generally only reliably detect metastasis if the node is already significantly enlarged, usually greater than 1 centimeter.
So relying only on CT could underestimate micrometastasis?
Potentially, yes, especially in the groin. It highlights a limitation of modern imaging for very small volume disease in those specific nodes.
But the true revolution, the thing that has really transformed surgery and is absolutely central to our theme today of minimizing mutilation, is the sentinel node concept.
Oh, absolutely. The sentinel node revolution is arguably the single greatest clinical advancement in managing early-stage vulval cancer. It allowed us to finally move away from the incredibly high morbidity of the traditional radical vulvectomy and routine bilateral lymphadenectomy. The surgery first described way back by Way and Taussig in 1935.
And that surgery caused.
It caused devastating lifelong lymphedema, that chronic, painful leg swelling at a huge percentage of patients because you were removing all the groin nodes unnecessarily in many cases where they were actually negative.
So contrast that historical approach with the modern sentinel node technique. How do we accurately find that sentinel node today?
We use specific mapping methods that rely on injecting a tracer substance around the primary tumor site just before or during surgery. The most common methods are either the intraoperative intradermal injection of blue dye.
Like isosulfan blue.
Yeah. Exactly, which has a nearly 100% detection rate in experienced hands. Or the use of radioactive tracers, like technetium-labeled colloid, combined with preoperative lymphoscintigraphy mapping and an intraoperative gamma probe to locate the hot node.
And the principle is simple.
Very simple. If the sentinel node, which is theoretically the very first node in the drainage basin that cancer cells would encounter, is negative for metastasis on pathological examination.
Usually done intraoperatively on frozen section.
Often, yes, or definitively on final pathology. If it's negative, then the assumption is that all the other nodes further up the chain are also negative. This allows us to safely avoid the extensive, high-morbidity full groin dissection, dramatically improving the patient's quality of life without compromising oncologic safety for appropriately selected patients.
Right. It's about selecting the right patients, usually those with clinically negative nodes and tumors meeting certain criteria. Okay, let's detail the individualized, conservative surgical treatment pathways now, stage by stage.
Right, so for confirmed stage IA microinvasive cancer, remember, 2 centimeters or 1.0 millimeter invasion, SCC only. We're absolutely committed to conservation. The standard is a simple partial vulvectomy, sometimes called a wide local excision, ensuring at least a 2 centimeter margin of normal tissue around the tumor.
And node management for stage IA.
Observation. No node dissection is needed due to that negligible risk of metastasis.
Okay, moving up to stage IB, where the tumor is larger or deeper than 1 millimeter, but nodes are still negative and maybe early stage 2. What's the rule for nodal management there?
This is where sentinel node biopsy has its main role. If sentinel node biopsy isn't feasible or available, or if it's positive, then we perform an ipsilateral inguinal node dissection, removing the nodes on the same side as the tumor.
Just the one side?
Initially, yes. But here's the major finesse, the individualization. Contralateral node dissection doing the other side is only required if that ipsilateral sentinel node or dissection comes back positive, or R if the tumor itself is centrally located, close to the midline.
Because of the crossing lymphatics risk.
Exactly. That 25% risk of crossing means you have to address the contralateral side if the tumor is central. But if it's lateral and the ipsilateral nodes are negative, we don't dissect the other side unnecessarily. Huge reduction in bilateral lymphedema risk.
Okay. Stage 2, which involves extension to adjacent perineal structures like the lower urethra or anus, that escalates the primary tumor treatment, right?
Yes. Stage 2 generally demands a radical or modified radical vulvectomy to get adequate margins around the primary tumor extension, plus mandatory bilateral inguinofemoral node dissection. Sentinel node might still play a role, but dissection is more likely needed.
And what about the pelvic nodes in stage 2?
The key landmark again is the gland of Cloquet. Pelvic nodes, those higher up nodes, are generally only addressed either via dissection or radiation therapy if Cloquet's gland itself tests positive for metastasis. If Cloquet is negative, you usually stop there.
Now, for stage 3, which by definition involves positive groin nodes, often extensive nodal disease, the strategy shifts entirely. Surgery isn't usually first anymore.
Absolutely not. The primary goal for stage 3, and often stage 4 as well, is to avoid the highly debilitating, life-altering surgery of pelvic exoneration, if possible. So we typically use neoadjuvant therapy first.
Meaning treatment before surgery.
Correct. This usually involves mega-voltage radiotherapy, often combined with concurrent chemotherapy, chemoradiation, delivered over several weeks. The goal is to shrink the massive primary tumor and the involved lymph nodes.
And if that works.
This shrinkage often allows for a subsequent, less radical local excision of just the residual tumor. It can essentially convert a previously unresectable case, or one requiring exoneration, into a potentially curable situation with much less surgical morbidity. It's a paradigm shift.
And stage 4, where the disease is even more widespread or involves organs like the bladder or rectum, also relies heavily on this multimodality therapy.
Yes. Particularly for cases with anal or distal bowel involvement, chemoradiation is often the preferred primary treatment. The sources cite the successful use of infused 5-FU and mitomycin C chemotherapy, along with radiotherapy.
Again, the goal is avoiding exenteration.
Exactly. It's a clear demonstration of using systemic therapy, chemo, and local non-surgical therapy, radiation, together to try and achieve cure or control while avoiding the historically high mortality and devastating morbidity associated with exoneration operations, especially in these often advanced and sometimes frail patients.
Before we transition to the vagina, we must quickly reinforce the pathology and prognosis of those rare invasive vulval types we mentioned earlier.
Right, the non-SCCs. First, Bartholin's gland tumor. This is a rare adenocarcinoma, usually unilateral, arising deep within the vulva from the Bartholin's gland. It often presents late, maybe as a persistent cyst, and carries a notoriously poor prognosis. It usually requires radical vulvectomy and often regional node dissection because it tends to be aggressive.
Okay, second.
Vulval sarcoma. Also rare, often seen in younger women, different cell types possible. Also tends to be highly aggressive locally and prone to metastasis, carrying a poor prognosis despite aggressive local excision. Chemotherapy might play a role depending on the subtype.
Then there's vulval melanoma. We know melanoma is dangerous elsewhere.
It is here too. It accounts for maybe 3% to 5% of vulval tumors. Often presents with those classic melanoma features. Irregular shape, variable pigmentation, maybe ulcerated edges. Treatment is always aggressive. Radical vulvectomy and mandatory bilateral node dissection because of its high propensity for early nodal spread. And sadly, the overall prognosis remains poor compared to SCC.
And finally, the slightly less aggressive one.
Right, the mildest of the invasive bunch. Rodent ulcer, which is just basal cell carcinoma, BCC. Like BCC elsewhere on the skin, it's locally malignant, meaning it can invade locally, but it almost never metastasizes. Therefore, it responds extremely well to just wide local excision with good margins. Prognosis is generally excellent. Okay, our final topic is primary vaginal cancer. And this is the definitive rarity in gynecologic oncology. It accounts for less than 0.2% of all female cancers. Just incredibly uncommon.
And it usually occurs in elderly women.
Typically, yes.
Yeah.
Often over 70 years old. And the major clinical challenge here, unfortunately, is its tendency for late diagnosis.
Why is that?
Well, the symptoms, like a watery or bloody discharge or maybe postcoital bleeding, they often appear quite late in the disease course. This means that only about 1/3 of patients actually have disease confined just to the vagina or immediate surrounding tissue at the time of diagnosis. Many present with more advanced regional disease.
Etiologically, what's the main type?
About 90% of primary vaginal cancers are squamous cell carcinoma, similar to the vulva and cervix, and often linked to HPV infection as well, especially in the upper vagina. But historically, we absolutely must remember the clear cell adenocarcinoma story.
Ah, the DES connection.
Exactly. This unusual tumor type was definitively linked to young women whose mothers took the drug diethylstilbestrol, or DES, during pregnancy decades ago. It's a critical example of transplacental carcinogenesis, something crossing the placenta causing cancer in the offspring years later. Thankfully, these DES-related cases are now very rare because the drug was withdrawn long ago.
We also have to remember that the vagina is a pretty common site for cancer to spread to, right? From other pelvic organs.
Yes, that's probably more common than primary vaginal cancer. Cancer of the cervix, the bladder, the urethra, the rectum, or even the uterus can spread directly into the vaginal wall. And a unique point the sources raise is that vaginal cancer can also arise over chronic decubitus ulcers.
Ulcers caused by pressure.
Exactly. Particularly in cases of neglected or long-standing mechanical pressure, like from a forgotten ring pessary used for uterine prolapse. Chronic irritation leading to malignancy.
Now, the lymphatic drainage in the vagina is perhaps the most critical and anatomical nuance here because it dictates the treatment fields, particularly for radiation. And it reflects that dual drainage pattern of the lower genital tract. This really demands mastery.
Absolute critical point. Let's elaborate on this dual drainage because it's key to surgical and radiation planning. You have to get this right.
Okay.
Because the upper part of the vagina is structurally and embryologically closer to the cervix, the upper vagina drains primarily upwards into the pelvic, lymph nodes, the external iliac, internal iliac, and obturator groups, just like the cervix does.
Right, but the lower part.
However, the lower part of the vagina, because of its proximity down towards the vulva, drains primarily downwards and outwards into the inguinal lymph nodes, just like the vulva does.
So if you have a tumor high up in the vagina, you're thinking about treating the pelvic nodes. But if it's low down, near the opening, you have to treat the groin nodes.
Exactly. This forces the radiation oncologist or the surgeon to plan highly specific and sometimes complex differentiated fields compared to dealing with a purely cervical or purely vulval lesion, where the drainage pattern is more uniform. You absolutely must tailor the treatment based on the tumor's exact vertical location within the vagina. Treating the wrong nodal basin would be a major miss.
Okay. Staging for vaginal cancer, starting with the preinvasive form, VANE, vaginal intraepithelial neoplasia. It seems simpler than vulval staging, focusing primarily on local extension. Stage 0 is VANE. Stage I is limited strictly to the vaginal wall itself.
Correct. Stage 2 means it's extended through the vaginal wall into the surrounding tissue, the pericarpium, but it hasn't reached the pelvic side walls yet. Stage 3 means it has reached the pelvic side walls. And stage 4 means it's extended beyond the true pelvis, or it's involving the mucosa of the bladder or rectum, or obviously distant metastasis.
And management for VANE, the pre-invasive stage, is inherently conservative, similar to how we manage VIN.
Yes, very similar principles. For VANE, we rely on local excision, CO2 laser vaporization, or sometimes topical 5FU cream applications. The goal is eradication with minimal morbidity.
But for invasive disease?
For invasive vaginal cancer, due to the difficulty of achieving wide surgical margins in a tubular organ like the vagina without causing major functional problems, treatment is usually dominated by radiotherapy, often a combination of external beam and brachytherapy.
Surgery is less common.
Less common is primary treatment, but radical surgery like a radical hysterectomy with total vaginectomy, gulpectomy, and no dissection can be performed in selected cases, usually for upper vaginal lesions. And pelvic exoneration might be considered for very advanced cases involving the bladder or bowel, but again, only if cure is possible and morbidity is acceptable.
Finally, we must cover the specific pediatric entity, sarcoma botryoides. This is a very rare and distinct tumor, isn't it?
Very rare, very distinct, and quite alarming when seen. Sarcoma botryoides is a highly aggressive type of embryonal rhabdomyosarcoma, which is a muscle sarcoma. It's seen almost exclusively in very young children, typically infants under 2 years old.
And clinically, how does it present?
It presents very dramatically, usually as a hemorrhagic sort of grape-like polyp or a fleshy mass protruding from the vagina. The name botryoides means bunch of grapes. Diagnosis is confirmed by biopsy, and then CT or MRI is used to define its local spread because it can invade adjacent organs quite rapidly.
And the treatment here is a major point of differentiation from adult cancers, isn't it?
Yes, a huge difference. The gold standard for treatment is not primary surgery. It's systemic chemotherapy first, using the well-established VAC regime that's vincristine, adriamycin, doxorubicin, and cyclophosphamide.
Why chemo first?
Because this tumor type is highly chemosensitive. The chemotherapy can often achieve dramatic shrinkage. Surgery is usually reserved for excision of just the residual local tumor after the chemotherapy has achieved its maximum effect. Radiation might also be used. This chemo-first approach has dramatically improved survival rates for this previously very lethal childhood cancer. #TagOutWorkDrift.
Well, this has been a tremendously detailed deep dive. We've spanned the global epidemiology. We've really drilled down on that critical 1 millimeter surgical threshold for microinvasion and explored the highly personalized management strategies required for both vulval and vaginal cancers. That theme of minimizing mutilation while maximizing cure, it's really evident in the shift from, the old way in toxic radical vulvectomy to the modern sentinel node technique.
Absolutely. And the key takeaway, reinforced across all stages of invasive vulval cancer, remains the pathological status of those groin lymph nodes. Groin node status truly is the single best prognostic predictor. It dictates not only the necessary extent of surgery, crucially, whether we can spare the patient a full dissection, but it also directly correlates with the probability of achieving that 90% 5-year survival rate, if the nodes are negative. Mastery in this field, I think, is really defined by your thorough understanding of those nodal landmarks, drainage patterns, and staging thresholds.
Right. Which brings us to our final provocative thought for you, the listener, to consider. Given the high risk of recurrence for VIN, remember 20% to 30% even after treatment, and the established fact that 5% to 10% of untreated high-grade VIN cases will progress to invasion within about 8 years. Coupled with the proven success of prophylactic HPV vaccination in actually preventing malignancy in young women, how should public health strategies best balance the clear need for lifelong, resource-intensive surveillance in those high-risk patients already treated, with the long-term success and, importantly, the coverage challenges of mass prophylactic vaccination programs?
That's a fascinating convergence, isn't it, of epidemiology, individual patient pathology, treatment, surveillance, and broad public health policy. Where do you best allocate resources for the biggest impact?
Exactly. The clinical focus seems to be shifting from simply intervening case by case towards mastering the much broader strategy of prevention and long-term risk management across populations. Something to think about.
Definitely food for thought.
Thank you for joining us for this rigorous deep dive. We'll see you next time.